We can have our panelists come up to the front.
Yes,
If our panelists want to take their seat at the front here, we can get started. Thank you all so much. We had a very invigorating morning, and it is certain to continue up through lunchtime. This will be a very special panel that will carry us to lunch, and then you'll have a nice long break where you can recover before our afternoon session. So this panel is going to be moderated by Dr. Roger Glass, who, as all of you I'm sure know, leads the Fogarty International Center and has led it since 2006. Dr. Glass is also a Harvard alum, having received both his MD and MPH here. He was a longtime leader at the CDC prior to joining Fogarty and has managed to maintain field studies in India, Bangladesh, Brazil, Mexico, Israel, Russia, Vietnam, China, and elsewhere. We are so thrilled to have him moderate this panel of our international speakers, one of whom is going to be coming to us live through video. So I'm going to hand it over to Dr. Glass. Thank you.
Oh, thank you so much. Hasn't this been an amazing morning so far? Huh? I think it was, I've heard Tony and Mark Dybel speak, and the candor and the insights that they gave us this morning were just extraordinary, and I hope you all taken note of that. I also have to thank the people here at the Harvard Global Health Institute, Ashish, Ingrid, Michelle, and Glenn, for bringing us together for this moment of celebration. It's really a celebration of PEPFAR, and as I think about global health in the 20th century was really tropical medicine, infectious disease, some HIV, but not much beyond. And I think it's because of PEPFAR, because of the HIV epidemic and the investments that have been made in this success, that global health in the 21st century will be much broader and get us involved in many other areas of health, but climate change, environmental issues, and the like. So in this session, while we've heard from PEPFAR from the US vantage point of view, we have 4 speakers who are clearly grounded in the field with tremendous experience in delivering PEPFAR programs. Their bios are in your handout, but up on this podium we have Prospero Okonkwo from Nigeria, who's responsible for providing care for about a quarter of the patients with HIV in Nigeria. Maureen Luba, an advocate, a huge advocate and youngster who will have a long career ahead of using her advocacy talents as a Harvard Global Health Women's Leadership Fellow to move the agenda into the future. On the screen, we have Nduku Kilonzo from Kenya, who will be speaking with us. She's waving her hand at us, so I'm standing here so she can hear me. So wave your hand at the audience, Nduku. There she is. Okay, there she, and Nzovu Ulenga from Tanzania, also in charge of AIDS programs there. So they're each going to present about 10 minutes about their perspective on how the PEPFAR program has changed, thinking about global health in their countries and the delivery of care and health systems into the 21st century. They'll each speak for about 10 minutes, and then we'll open it up to a dialogue amongst us, and then we'll open up for questions from all the audience. So, Prosper, do you want to begin and tell us about PEPFAR in your country and how it's changing things and how it's evolved over time? What is your experience?
Good morning, ladies and gentlemen. Again, it's a pleasure to be here, and I really agree that we've had a very interesting session this morning, and most of what I'll be speaking to will just be to amplify some of the things with specific examples. And again, this is not like a full presentation because it will be more of discussion. And because we have 3 of us on the panel, I want to just speak broadly to the global health perspective, particularly looking at systems. I think the first thing to say is that, yes, the PEPFAR has really changed a lot of things in our countries. I'm sure we've all seen this. But the first thing I want to say, just to agree with the earlier speakers, was that in the late 90s and early 2000s, HIV was actually a death sentence. In Nigeria, when we started in 2001, our president at the time asked that 10,000 people be put on treatment, and it was at $7 a month. This was at a situation where, for the private sector, it cost $350 to put a patient on treatment for a month in a country that had a GDP per capita of $750. A country where 75% of the total health expenditure was out of pocket, and a situation where less than 5% of the people were on any form of health insurance. And when I say that people who were queuing up at the time actually asking that people move on, what I really mean is that they were wishing that those patients that had been put on treatment in the government program kind of died so that they could take the spot. It was that bad. The patients, the place that I highlighted in red, so this is a patient's testimony that when PEPFAR fully came in, we started getting the drugs and the lab tests for free. And that was when the patients started coming out. I just want to emphasize that, because a situation where people knew that they were positive, and they were not confident that there would be any treatment, it just drove them down. But disclosure began to increase as we saw a lot more of these patients. There's no doubt there's been a massive scale-up. From 25 sites that the government of Nigeria asked for the program to happen, we find that we have thousands at this time. And the group that I work with, by the way, APIN, maybe I should just go back a little bit, because that's one of the gains of the PEPFAR program. APIN started as a project of the Harvard School of Public Health when Phyllis started the Gates program in Nigeria. But we're pleased to say that we have gone from being a project to now being a local implementing partner that has been in existence. We're actually in our third iteration of the PEPFAR 5-year cycle. And I think this is a gain of the kind of things that PEPFAR has done. Just like the sites have grown, the number of patients on treatment have also grown from less than 10,000 at the beginning to 1-something million. And PEPFAR does account for 75% of those numbers. Just to make it more graphic, I think we should see that at the end of 2018, more than 140-fold number of people on treatment. Also to say that the infection has gone down considerably. I'm sure many will say if the treatment is doing well and patients are living longer, maybe the prevalence will be high. But I think the most important thing is that, though it's not a slide that is here, we find that 59%, between 2003 and 2018, new infections had gone down by 59%. But while we have a new prevalence that after our survey last year of 1.4, I just want to emphasize that there is still great geographical diversity, which means that we have pockets of different epidemics that we are addressing separately. But I think what I just want to say is that PEPFAR has indeed positively influenced the health system in Nigeria. And I think time will fail us to just say, but I just want to just speak to a few issues, because I'm looking at my time. One is that a lot of the resources for HIV work, we also know from Mark's discussion that even what we call Global Fund is actually partly US funding. So a lot of the money does come from PEPFAR. Second is that, around leadership and governance, we now have more structured coordinating mechanism for things that happen beyond PEPFAR. The way government does things has begun to change. We are not really there yet, but things have begun to change. Because of the need to manage the resources of PEPFAR very well, we've begun to build systems that address such accountability standards. And then one of the good things about that is that it's now beginning to bring up non-state actors like APIN, who can now apply and get other grants, Global Fund, World Bank projects, which I think is something that is very, very positive about what PEPFAR has done for us. One other area that I think we've done quite well in Nigeria is the unification of our logistics system. Before, UNFPA will be buying family planning commodities, Global Fund will be buying malaria, but now PEPFAR has brought together our logistics system so that we can do pool procurement that we all agree comes with a lot of efficiencies. And the discussion has gone on this morning about data. It's been really transformational. We remember when we started, we had what we call medical record officers, who, many of them were like afraid to touch the computers. But we've gone from that stage to stage now where people can do a lot of things, involving even analytics with data. We find that for the sites that APIN manage, all of our sites, even primary healthcare sites, are on electronic medical records. And it's gone beyond that now that PEPFAR doesn't even need to be asking us how many patients you have on treatment, because there's also a functional national data repository where they can just go and access all clinical outcome and experiences. But I think one other thing that's important that I need to speak to, particularly because Roger is moderating this group, is that the kind of quality of data that we have has kind of encouraged learning. A lot of the forgetty things that are happening are because we have data that we think are good data that we can use for learning and research. Of course, health workforce, I think we can speak to that as we get to the next stage. It's been transformational. Apart from training people to do this, people that before now we would have thought did not, we call them lay people, have roles that are really, particularly now as we begin to move towards differentiated care. They have roles in the community that are very complementary, that makes the work that we do very, very easy. One area that I think I must emphasize, and particularly because we had the experience of having started as a program that Phyllis Kanki helped us to build, is that we have built a lab system that we think, without sounding immodest, is able to do quite a few things. And, the infrastructure has been tremendous. With the support that we are getting from PEPFAR. At this stage now where the third 90 is becoming a critical issue, the number of patients that need to be to have their viral load tested are things that this system is able to respond to. And we're also happy to say that quite a few of our public health laboratories have gone through the stepwise accreditation to become ISO certified, which is now helping them to be able to do some of their research activity. This is a life story of when we came to start in Jos, and we're saying, where do you have your lab? They say, if you can take this carpenter's shed. This was truly a carpenter's shed, and we'll find a situation where we now have state-of-the-art laboratories that can do things from serology, even to resistance testing. In this lab in Makurdi, for instance, now, because PEPFAR just gave, as one of the 6 mega labs in Nigeria, it has 4 Abbott systems that is able to do 3,600 viral load tests a day. So things have really changed. And these are some of the testimonies from our leaders. Unfortunately, this is one of the problems we have, the turnover of our leaders. Before they settle down to understand PEPFAR or the program, we'll find that they move on. But at least it was obvious and evident that a lot of things happened through PEPFAR. To round up, I just want to say there are still a few unfinished businesses. We just completed the population-based survey last year, which despite the fact that we now see that we have a lower prevalence, but we also see that the spread. If you look at the 7 red states that are in the left quadrant, left upper quadrant, 500,000 patients are needed to be put on treatment for us to get to epidemic control. 60% of those numbers are in those 6 states. So a lot of effort is now being put in these 6 states to ensure that they all move towards the green area lower, where you have high saturation and low unmet need. A lot of the other yellow that are hanging around are states that, though the unmet needs are low, but they're also not saturation. So the idea is that by 2020 September, we expect most of these sites to move, most of these states to move to the lower quadrant, where we have everything as green. And then to say that a few other unfinished businesses that have come up this morning in our discussion are things that, in Nigeria, when we say political commitment, we like to add demonstrated political commitment. Because one of the discussions is that a lot of investment has happened, that it must get to a stage that this thing should not fall apart. And I think that is where PEPFAR is helping a lot now, because the push is there on Nigeria. You have to help do this so that we are sure that these gains are sustained. And then, of course, we have the issues directly linked to that of some user fee situations where government has accepted responsibility, but in practice, some states are doing better than the others. Just to round up, to summarize that, though not with some challenges, this has truly been a transformational program. And again, just to emphasize, not only to the HIV program, but to health in general. I think my time is coming up. But to also say that a few other things have happened, and I'm sure we can discuss this as we get into the next session. Thank you very much.
Great. Now we're going to bring in Nduku from Kenya. She works as the executive director of the National AIDS Control Program. And here she is. Nduku, can you hear us? We need to get a little voice. Just a second. Nduku? Just a second. Is it coming up? Turn up the volume. Are you on mute, Nduku? Try now. I can hear you. Can you hear me? No, we can't hear you. Are you on mute?
Can you hear me?
Yes, yes, there we go. There we go. Bango. Okay, so I've just introduced you, and so we'll let you have your 10 minutes to tell us about your program in Kenya.
Thank you. I've just got my off the so you will hear a little bit of that.
Yes.
But I hope you can hear me. So thank you very much. I really want to give this opportunity, presentation, opportunity in person. But I really just wanted to first just give a few reflections and about the journey and the contribution of PEPFAR. And as I have this discussion, I will probably try to look at how we have been able to localize the health gains that we have experienced in the HIV response from the global health. And I want to use the example, or I want to keep referring back to the question of VCT, because it was really one of the first programs, but importantly, it is the entry point to our presentation, our response. In the early days, there was no knowledge of HIV. There were a lot of myths. There was no science, or at least everyone was trying to figure out what was going on. Public health was equals to doctors and hospitals. It was not about communities. AIDS was really about morals, and VCT was really the idea of voluntary, and the idea of counseling was really preparing people to die. And the stigma and discrimination, I remember even saying the word VCT or HIV was a challenge in those days. And at the beginning, when therefore VCT started with PEPFAR resources, VCT and being able to test was initiated. And what we saw was significant response of partners across the globe. One was obviously the global community, establishment of UNAIDS, Global Fund. All of them supported significantly through PEPFAR resources. And began to see governments. I know that my own government then got to a point where HIV was declared a disaster, national disaster, in the 90s. And it was, I think, for me, reflecting back what that has been, and then as I start to talk about where that takes us, is thinking in the context of where we are today. Everyone is talking about universal health coverage. And everyone is talking about it in the context of quality of services, in the context of access to services, and in the context of relieving the financial pressure on people to do it. Perhaps if we all take a step back, I think we can say that with the support and resources that we've had from PEPFAR and the coming together of the global health movement, we've already achieved all intents and purposes, in many ways, UHC, but for HIV only. And so we were able, with those resources, to be able to have public health system strengthening. And this included issues related to provider training, guidelines, standards, strengthening of laboratories, quality assurance, and mechanisms and commodity management. Data, I believe data has been talked about a lot. So I won't talk about data except to say that even when we had to start with anonymity, for those of us who were there in the early days of VCT, you couldn't even have somebody's name and title. You had to, name on the VCT form. We collected anonymous data just because of how much stigma was associated to it. Thereafter, we then had a lot of access, which was the demand side. Creating enabling environments. I think about services for key populations in Kenya, or testing for adolescents and young people, which would in many forms and shapes not be considered legal. The HIV response was able to navigate around that, and PEPFAR put in a lot of money to support community action, which then led to greater community voice. But in addition to that, in addition to just collective voice, was also individual voice, local capacity among people, among Kenyans. And I think that when I look back at my own personal history, I joined civil society after school, and I learned a lot. And who I am today and being a policy maker is also in many ways having been supported by PEPFAR resources, both in training, but as well as also capacity building. And it was this creation of demand. And we also then began to see significant partnerships and government really taking charge of the response. Over the years, then what have we seen? In Kenya, the prevalence has moved from double digits to about 6% or below. Incidence was unknown at some point. We thought it was about 150,000 people per year. We now know we are about 46,000, and our population-based survey can tell us that deaths have reduced significantly from more than 120,000 a year to less than 25,000 a year. So there's been significant progress in the quality of life. So even with all this progress, what could have been done better? Perhaps what could we do better? And I think one of the biggest issues has been the limited or the investments in communities. Whereas we talk about having invested a lot and working a lot with communities, we also do note that when we come to long-term systems for communities, like routine data collection for communities and so on and so forth, each donor has their own way of doing it. There hasn't been the same investments in national systems as perhaps you have seen for the health sector through DHIS, for instance. Another item I think has been thinking a little bit about for the resources that are available, could we be getting more money for more health for the money that we have? And I think about, for instance, the Kenya program, and look at where is it that we could have we could gain more in terms of better coordination. We have many partners. A lot of times it is unclear sometimes what they are funded to do, how those funding models work. And so being able to leverage the most for the resources that are available still remains a bit of a challenge. And I think one of the other items has been the constantly shifting focus. So I sometimes think about the emphasis that we have not laid as much on condoms. Somewhere along the way we started with condoms, we have kind of taken or not been able to continue pushing that. And yet we know it's not, when we think about condoms, it's not just about HIV, it's an intended pregnancy, it is other sexually transmitted diseases. And I know we know that in places in Kenya, some studies are showing that there are places where we are now seeing an upsurge, a recurrence of incidents of other sexually transmitted infections. So I think there are places where we could have done better. But in terms of data, I think the biggest one is what the economists that have been told referred to as fungibility, because at the country level, I have gone to the National Treasury and said, give us resources because we will need resources for the HIV response. And I have been told, but you have way too much money. So I think it's about how do we relate to say that these resources are helping us, but at the same time, we have to invest more. We have to think about where our future as countries are going to be, even with diminishing resources and even with PEPFAR diminishing resources, or how are we going to be able to complement? So what do we need to think about moving forward, which is where I want to spend the next 2 minutes that I have. And I think the first is recognizing that we have demographic transitions. Even as we think about where we want to go, we have the median age of young people in most parts of the world is significantly lower, which means that as they grow older, we are going to have more incidents, even if we retain the current rates, for instance, of transmission among young people. Or we would then have higher costs related to healthcare because of average age increases. Then we have transitions. Today, people living with HIV are perhaps more likely to be dying of non-communicable diseases related to heart disease, related to various cancers, related to... So how do we make sure that we start moving towards treating the person and not just the disease, so that if I come to my CCC and I have diabetes, blood sugar disease, whether related to ARV or not, but I am someone living with HIV, or I have a cardiovascular disease as a person living with HIV, how do I then get ARVs, but also get those other services? Because that is what we have to start grappling with. Do we have to rethink our service delivery models? And finally is financing transitions. And all said and done, I think what PEPFAR has been able to demonstrate for us is that we do have the opportunity to be able to learn and leverage as we move towards thinking about broader health from the HIV response. We do have the systems that we have been able to build. We do have lessons from engaging communities and for community action that will become key as we move forward into broader health, because that's the only way we are going to do two things. One is achieve UHC, but secondly, and importantly, is to be able to continue to make reversals in a lot of the disease areas that we are seeing that will have impact for HIV moving forward. So certainly we have learned a lot, we have gained a lot, and there's still a lot more that could be done so that we are more efficient. Thank you.
And Nduku, that was lovely. We heard you loud and clear, and we'll come back to you on the comorbidities issue and stigma and how to go forward. Next presenter, Nzovu Ulenga from Tanzania. He's head of the director of the Health System Strengthening, Management, and Development of Health. Will you speak from there?
Good morning, everyone. I would like to thank the organizers for inviting me to share progresses that Tanzania have done in the past 15 years. I would like to share with you progresses that Tanzania have made in the past 15 years of implementing PEPFAR in the country, focusing on successes, challenges, and lessons learned. My name is Nzovu Ulenga. I'm a former PhD student in Phyllis's lab at Harvard School of Public Health. And after finishing my study at Harvard School of Public Health, I went back to Tanzania to work at MDH, a local NGO now supporting about 500,000 HIV patients in the country. This was an organization that started as the work that Phyllis Wafai at Harvard School of Public Health was doing in collaboration with Muhimbili University as well as Dar es Salaam City Council. And as you can see in the picture there, that's President Bush in his second term when he came to visit our organization, witnessing the work that we are doing in Tanzania. So MDH as well as other organizations in Tanzania, have done a lot. And I want to spend the next 10 minutes or so just highlighting, how far we have gone in fight against HIV in Tanzania. So Tanzania is a country of about 60 million people. And as we speak, about 5.1% are affected with HIV. And when you look at the geographical distribution, it really varies. You have regions that have prevalence that as high as 11%, for example, Njombe in the south. But you also have regions that have prevalence of only 0.3, as you can see, Lindi. But when you look at gender, women are the most affected. We have 5.7% of women are affected by the disease, while we have, for men, is only 3.5. Equally, for young women, when compared to young men, women have the prevalence of about 2.2%, while young men is 1.2. So when you look at the new infections that are happening per year, we have about 72,000 people being infected by the HIV every year. And the adult aged 15 and over, it's 64% of that. And when you break that down among men and women, you also see the number of people that are being affected. 36,000 women, while men is about 27,000. And for children, each year we have about 8,600 that are being infected by the disease. So in terms of incidence, and this just focusing on adult, it's about 2.5, but when you put the entire population together, we have incidence of 1.4. When you look at the population of individuals living with the disease in the country, so as I pointed out earlier, in Tanzania we have 60 million people, and among those, 1.6 are living with HIV. And among those 1.6 million, you have 1.2 that are aware of their status, aware of their HIV status. And that represents about 78%. And among the people that are living with HIV, 1.1 million are on ART treatment. And that represents about 71%. And overall, about 960,000 people who are on treatment are suppressing viral load. And that is about 62% of all the individuals that are living with HIV in the country. And here I just want to share a very brief picture on the treatment coverage in the country. So you can see that 72% of all the individuals that are living with HIV in Tanzania are on treatment. 71%. But when you look at adult, it's about 72%. And the coverage among women is about 82%, but we are a bit behind for men. It's only 57%, and that's due to the fact that it has been a challenge reaching men in Tanzania, especially identifying men that are HIV positive, linking them to care. It has been challenging. Later I will have an opportunity to share with you some of the strategies, some of the approaches that Tanzania is trying to employ so that we can cover the gap that you see among men in terms of treatment. And about 65% of all children that are living with HIV are on treatment. And also that area is an area that we are behind in terms of coverage. When it comes to elimination of mother-to-child transmission, 93% of all women that need PMTCT support, they receive it. And that represents about 76,000. However, the actual need is 83,000, so we also still have a gap. And a bigger gap we have is diagnosis, HIV early infant diagnosis of children that are born from mothers that are HIV positive. Currently, we are able to screen only 47%. So that's an area of challenge, but we are working hard to make sure that we close that gap. With the coverage picture that you see there, the country is making progress in terms of identifying HIV positive, but also linking. You can see in 2005, we were identifying about 260,000. And last year, that number went up. We are identifying about 200,086, but this year we expect to identify even more. And again, when you look at the number of individuals, a number of HIV positive individuals that are being linked to care, in 2005, we were able to put about 169,000 people on care. But last year, that number increased to 269,000. But when you look at data, this year, this number will go up. With that kind of progress, you also look at the viral suppression. Now, 89% of all the individuals that are on care have suppressed their viral load. So I just want to end here. When you look at the number of people living with HIV, number of people who get infected with HIV every year, but the number of people that are being put on care, on average, we are putting on care almost 3 times of the new individuals that get infected. So that tells us if we continue in this direction, we have an opportunity to catch up in terms of putting all the individuals that are HIV positive on care. And the evidence is clear. When you look at the prevalence, you can see a downward trend. For example, on the graph on the left, in 2012, in 2002, when we started collecting this data, you can see the prevalence was about 7% for overall population. Right now, we are talking about 5.1. The same when you look at positivity rate, and this is positivity rate among children that are born from mothers who are HIV positive. And in 2011, that stood at about 12%. That number has gone down to about 3% as we speak. So as a country, we are making progress, but challenges still remain, especially reaching hard-to-reach population. And these are key populations such as commercial sex workers, MSM, injected drug users, young women and young men. This population, it is still very difficult to reach. Apart from that, we have a huge number of individuals that are linking to care. And then after 6 months, 1 year, they are nowhere to be seen. So basically, right now, the challenges that we are facing in Tanzania is now, regardless, and Mark was talking about this earlier, that in earlier days of PEPFAR, people who came to treatment, these were sick people, people who come to the health facility in a stretcher. So it was easier for them to stay because the incentive was, I take this drug to stay alive, to feel better and resume my daily work. Right now, you initiate ARV therapy to an individual that is just feeling well. You just happen to diagnose and say, you have HIV/AIDS, but otherwise they don't have fever, they don't have rash. So how do you convince somebody who otherwise feel normal to continue coming to clinic to get the drug? And sometimes, they live very far from the clinic. So we have experienced a huge number of people who are initiated on drugs, but they end up disappearing. Basically, they don't come back to the clinic. So this is the challenge that we are facing, but we have a number of strategies that we are putting in place to try and reverse that. So with that, I thank you, and I look forward to a discussion after this. Thank you.
Okay, you raised a number of questions that we'll come back to, but our last speaker is Maureen Luba from Malawi. She's done advocacy for 10 years and is going to tell us about her advocacy activities overall and with young women. So welcome, Maureen.
Thank you so much, Roger, for that introduction. Just to add that I am indeed an advocate and a very passionate champion for young women's health and rights. 6 weeks ago, before I came to the US, whilst I was still back home, I got a phone call from a head teacher for one of the schools where my friend and I, has been going out to mentor some young girls who are in primary school. And he said, one of the girls that you've been mentoring has been selected to 2 amazing secondary schools. And I was like, wow, that's great news. I was so excited by that time, and I was dancing. And he said, yes, but we have a problem, and I was wondering if you could come. Apparently her parents are saying they can't afford to pay for the tuition fees. And her stepdad is already suggesting that she should drop out and just get married. When I heard that, my heart sank. The following day, my friend and I went to meet the girl and her parents, and what I saw there even broke my heart more. I saw a family in dire poverty. The news about the selection of their daughter, instead of bringing joy to the family, brought a lot of depression. I looked at this girl with tears running down her cheeks. She knew that if no one was going to come to her rescue, that was the end of her bright future. And I asked her, how much is the tuition fees? She said $70. I looked at her and said, you know what, sweetie? I don't have the $70 with me right now, and neither does my friend. But one thing that we can promise you is that my friend and I will do whatever possible, to make sure that you go to school, you stay in school until we finish. Well, the good news is that the girl is in school right now. But unfortunately, there are so many amazing, brilliant, and smart young women who are dropping out of school simply because they can't afford to pay for tuition fees. And sometimes it's as low as $20. I don't know what you use your $20 for, but next time you're spending $10, just remember that it could be tuition fee for some girls somewhere. So I know some of you are wondering, what does this have to do with HIV? Well, it has a lot to do with HIV. Because we know that when girls drop out of school, they are likely going to end up becoming victims of early marriages. And most of the times, they're not getting married to their peers. They get married to people who are older. They become victims of gender-based violence. They become victims of sexual abuse. And some of them are likely going to end up in transactional sex simply because they have to meet their basic needs. So all these factors actually put adolescent girls and young women at risk of HIV. Which is why when you look at the global statistics, both global as well as regional statistics, you see that the number of new HIV infections is higher among young women than men of the same age group. And this is actually a graph from one of the recent UNAIDS report. And it says it's actually 60% higher than among young men of the same age group. And this is the same trend that we are seeing in Malawi. This is actually data from a RECENCY study that is actually going on, which is also telling us that, we're seeing highest rate of new HIV infections, among the youth aged 13 to 24. And when you go further to disaggregate by sex, you actually see that, young females are the ones that are registering more new HIV infections. Well, Malawi is one of the poorest countries in the world. The total population is at 18.6 million people, and our HIV prevalence rate at the moment is around 9.8%. When you look at in terms of government health expenditure, and when you think in relative terms, when you compare to other countries within the sub-Saharan African region, you find that Malawi is spending more, about 10.8% compared to 6%, which is the average for the region. But because our GDP is so small, when you think in absolute terms, you actually say that Malawi is spending low, about $34 against $114, which is the regional average. But also according to the recent assessment which was done by World Bank, as a country we have a very limited fiscal space for additional domestic health spending. The first HIV case in Malawi was diagnosed in 1985, and by 1999 the HIV prevalence was around 16.2%. By that time, the health system was quite overwhelmed. There was overcrowding in the facilities. We lost so many of our dear and loved ones to AIDS, who left behind orphans and child-headed households. And by that time, stigma was very, very, very rampant, just like my colleagues have already said. And until in 2004, when we were able to launch the HIV treatment program, and with support from Global Fund, we were able to put around 3,000 people on treatment. Well, to date, out of the 1,060,000 people that are living with HIV in Malawi, more than 800,000 are actually on ART, thanks to PEPFAR and Global Fund, of course. So how has PEPFAR contributed to the success in Malawi? Well, over the last 15 years, PEPFAR has invested more than $800 million to the HIV response. And these resources have been largely used to strengthen the health system, promote access to HIV prevention, treatment, and care services, as well as help mitigate the social and economic impact of the disease. So what are some of the game-changing interventions where there's a lot that PEPFAR's done in Malawi, which I wouldn't present in 10 minutes, but I'll just share with you a few highlights, which I feel like have made a huge impact in the HIV response in Malawi. The first one, which is also my favorite and also quite laudable, is the DREAMS program, whose overall goal, of course, is to reduce new HIV infections among adolescent girls and young women. And one thing that I like about the DREAMS program is because it takes a holistic approach, whereby it goes beyond just addressing the HIV needs of adolescent girls and young women, but also look at the social, economic, and cultural factors that are ingrained in the lives of adolescent girls and young women. When you look at the package itself, it's actually quite comprehensive, and it touches on all the germane factors, again, that have got a bearing on the lives of adolescent girls and young women. The program was announced in 2014, and in 2015, Malawi was listed as one of the DREAMS focus countries. And as of today, the program is being implemented in 3 districts. And to date, we've actually managed to achieve a 53% reduction in new HIV infections among the 15 to 19-year-olds, as well as a 30% reduction in the 20 to 24-year-olds. Human resources for health is also another area where PEPFAR has actually made a huge impact. Malawi continues to face a critical shortage in human resources for health. And at the moment, we have 0.5 professional health care workers per 1,000 inhabitants, which is only around 1/9 of the WHO requirement in order for us to meet the UHC and SDG goals. So in order to help address that, PEPFAR has been investing in pre-service training to make sure that we are producing additional healthcare workers. But PEPFAR has also been providing salary support to healthcare workers in the country. At the moment, PEPFAR is supporting more than 9,000 healthcare workers, both at facility and community level. Well, just like Nigeria, Malawi is also currently transitioning from what has been largely a paper-based medical record system to an electronic medical record system. And the goal is to make sure that we have data that is accessible to all the stakeholders, but also at the same time to make sure that the data is available in real time and it is of high quality. Well, PEPFAR has also been very, very instrumental in supporting our government to making sure that, they are putting in place right and evidence-based policies. And to date, we've got quite a number of beautiful policies, that are in existence in Malawi. But you will all agree with me, but that, just having these policies on paper, is not enough. We need to make sure that they're being fully implemented. And that is one of the areas that we need to focus on moving forward. Well, things even got more exciting when PEPFAR decided to open up the space to civil society in 2015. And ever since that time, PEPFAR has been engaging civil society in the planning processes, even during implementation as well. And civil society have been very, very instrumental in providing profound feedback, which has then been used, for cost collection as well as overall improvement of the program in general. So where are we with the epidemic? Well, as a country, we've made quite a remarkable progress. Just recently in July in Mexico at IAS, Malawi, in a report that was done by PEPFAR, AVAC, and the Friends of the Global Fight, Malawi was actually listed as one of the 6 locations that have made remarkable progress towards ending AIDS. And it's all because of PEPFAR support and Global Fund support. Whilst other countries are still talking about the 1990, we are already talking about the 95, because we have already surpassed our 1990 targets. But moving forward, there's a lot that needs to be done. The DREAMS program, it's such a nice and beautiful program. And I just want to take this moment to thank you, Ambassador Bex, for being so ardent and passionate about issues to do with adolescent girls and young women. But we know that we need to reach out to more. And we know that for the program to expand, there are preconditions. But I just want to mention that whilst we are waiting for those preconditions to be met, there are so many adolescent girls that are continuously falling into the trap or situations that can be quite irreversible. So there's need for us to make sure that we reach out to more adolescent girls and young women, and we don't have time to wait. Another area that as a country we need to focus on is around HIV prevention. I feel like Malawi as a country, we've done quite a lot in making sure that we are putting more people on treatment. And we have such an excellent treatment program. But we're not doing so well in HIV prevention. By the end of this year alone, we're expecting, around 38,000 new HIV infections. That's quite, staggering if you consider a country that has a population of around 16.8 million. So this is an area where we need to make sure that we are also putting a lot of effort to make sure that we're reducing the rate of new HIV infections. Again, we need more HRH support. It's still needed. And lastly but not least, as we're getting closer to epidemic control, how do we make sure that, how are we going to sustain the gains? And how do we make sure that there's actually increased local ownership of the program? Thank you so much.
There she is. Okay, Nduku, can you hear us? We're going to start she's quiet again, but let's get her turned on. Okay, so you've really heard from workers in the field who are handling enormous and incredible programs for HIV treatment and prevention. After 15 years of the program, incredible success like we just heard in Malawi, reaching the 90-90 goals, and the DREAMS program, Debbie, that's been so influential in that area for young women. Where have governments picked up over the 15 years? What have been the areas where their engagement has increased over time in terms of laboratory systems and data systems that have spread throughout? Prosper, do you want to start and just give us some ideas of how laboratory engagement for HIV might have infiltrated other areas of the health system or data systems?
Well, I think, thank you very much. The truth is that a lot of what has happened in the laboratory system has been driven by PEPFAR, much less so by Global Fund. But I think what PEPFAR has started to do in the last maybe 5-10 years is to move ownership. I mean, these are infrastructure that had, cost a lot of money. And then PEPFAR is now saying that the laboratories can also be used for things that are not necessarily PEPFAR, once we can delineate the sources of reagents, for example. And that even became more necessary because there was a paradigm shift in 2014 when some elements of the treatment package began to be transitioned over to government. For instance, chemistry, hematology was no longer directly being supported by PEPFAR, despite the fact that the equipment for those were equipment that were put in place by PEPFAR. The success has been varying. In some states, that was the point I was trying to make about the emergence of user fees in HIV work, because in some of the states, PEPFAR has given this guidance that every state should try to eliminate that bottleneck to service. And in fact, the advocacy in Nigeria is like, if PEPFAR is putting $100, that the 50 cents that you need to put to make this to happen shouldn't be a difficulty. Some states have responded because the 7 states I showed that had the red, that bore the bulk of the disease, we are made to sign memorandum of understanding indicating that they needed to do that for funding to continue. In some states, it already has translated to cash so that these patients are paid for. But in a few other states, it's still a challenge. And what that now means is that those costs now fall back on the patients. And of course, you can imagine that that becomes a cause of attrition. But having said that, I think one other thing that's happened is that the fact that capacity of even people that are like health workers in the government system to be able to manage some of this is becoming something that we're seeing that I think is very positive. And also locally, we're also beginning to, government is also beginning to train people who are like, not necessarily biomedical engineers, but people who have that skill, because preventive maintenance is such a big issue. So on the whole, I can say that they are assuming responsibility to a certain degree, but in the last 1 or 2 years, the kind of direct emphasis that there will be consequences if these are not done well is trying to increase what we are finding. Because that's why I was using the word demonstrated political commitment. At times, you find that governments will say, yes, we are willing. I mean, we have this cliche in Nigeria that when it comes to like providing funding for programs, it's like a cascade. The first issue is that, is there a budget line? Most times the answer will be yes. The second is that, is there appropriation for it? Once in a while, yes. The third one is that, is it funded? And then you go down to, is it actually released? So people move within this cascade at different levels. The intention might seem to be there, but it's just reflecting now on a few more governments, because we are now beginning to realize that not doing this will have consequences.
Okay, great. Nduku, can you hear us? Are you there?
Yes, I can. Hear me?
You mentioned the issue of stigma, and I wondered, stigma was terrible at the beginning of the HIV epidemic when it was a death sentence, but now it's a chronic disease. How has stigma changed, or has it become more open, making it easier to provide treatment? Can you tell us about how stigma has changed, or does it remain a key impediment?
There's been significant improvement as far as stigma is concerned from the perspective of community-related stigma, as well as self-reports of stigma from persons living with HIV. And I say that because we see the uptake of services quite significant. However, when you start to then disaggregate by population, so for instance, among young people who are in schools, or in some places among key populations, or in some communities you find that then stigma changes. So in some parts of Kenya, you will find that there is very, very little stigma, even when we do the index. And then in some parts of Kenya or within some communities, there is still significant levels of stigma, so much so that they actually affect uptake of treatment, and especially among adolescents and young people. And I don't know whether I can take the moment to just say something in relation to the question you asked about what government has been able to take on. And I think what we've been able to mostly, what I would say has been the biggest gain in this process moving health systems that can be leveraged for the broader health sector has been the idea of national priorities, national, where the country says, okay, these are our priorities, this is where we need to go. We have the global obligations that we need to meet if it's 90-90-90. But at the same time, as a country, you know, we are thinking about this. We think this is where our priorities, we think this is what is most affecting these sorts of populations. And I don't think we would be there because we are not necessarily always there in other disease areas if we didn't have the infrastructure and the capacity that we have built over time, or that has been built over time with the resources that have been availed, because it takes people as well as the capacity and capability to be able to do that.
Okay, thank you. And Nzovu, you mentioned the problem, and one of the keys to eliminating or having AIDS treatment in a generation is screening people and putting them on care before they're symptomatic. And you mentioned this as a problem of keeping people on care for life when they're HIV infected but without symptoms. Where is the research agenda to get people to stay on treatment for the long term to prevent resistance and to prevent disease? Is there a research agenda that you see in Tanzania for this?
Yeah, thank you. As I pointed out in my presentation, that almost, I will say, 70 to 80% of all the individuals that are identified to be HIV positive are people who are healthy and people who otherwise you cannot tell by just looking at them that they are HIV positive. So a large number of them are identified from the community, basically through index testing, through community outreach. So you go to a village, you go to a street, set up a tent and start testing. You link that person to care. You could provide the medicine right there and then say, you know, after 2 weeks, come to the facility. With the follow-up, with reminder, with phone call, after 2 weeks, they will come to a facility. The facility could be, you know, half an hour away, could be 2 hours away, sometimes could be 5 hours away. And that have cost component to it, meaning that they will have to pay bus fare. They can come to a facility 2 or 3 times, but at some point they will start asking themselves, how do I feel before taking the drugs and after taking the drugs? And for most people, there is no difference. And the reason why people go to seek health services is because they are not feeling well. And for the case of HIV, for individuals that are otherwise, you know, health, there is no such incentives. So at least what we have been trying to do in Tanzania is to look at the counseling training that we have been providing to healthcare, meaning that the persuasion in the area was, you know, come, you feel better, you go back to your normal activities. Right now is come is for your, you know, health well-being, meaning that if you continue without treatment, you now run a risk of developing HIV. You run a risk of developing other opportunistic infection. This medicine that will be coming to take every month at a health facility is an insurance to ensure that, you know, AIDS, even though it's now part of you, it's in your blood, it will never affect your health. Again, that's the new type of thinking in terms of counseling. But when it comes to overall healthcare workers to be able to implement and get that message across, we still have a long way to go. And apart from that, it's the message that most people understand, but we touched earlier on the data system. It's easier to track people because, for example, even if somebody doesn't show up at the clinic, if you have a phone number, if you have a way of reaching out to that person, you can call them, they will come to the health facilities. Right now, without proper data to be able to identify such people, especially when they travel, we have this mobile population of miners, fishermen, but as well as long-distance lorry drivers, people who are moving from one place to another. Having no way to track movement of such people basically will continue to have and experience this problem of loss to follow-up, meaning that losing patient from care. In terms of research, where are we in terms of addressing loss to follow-up or convincing people who are otherwise healthy to continue taking the drugs? In Tanzania, there's no research that I know. People are thinking about different ideas, but we don't really have concrete research idea that can be implemented in the country.
Mm-hmm. Let me ask the audience to prepare your questions. I want to ask one last question to Maureen. Do you want to comment, Prosper?
Yes, please, just to say that this is also a challenge in Nigeria, but I think there are a few things that are happening, one is that, like you said, the enhanced counseling for people to stay on treatment. But I think the problem actually became a big issue when we started test and start. So what really constitutes starting immediately? Is it one day or giving another week for them to process the issues? Mm-hmm. So those are issues that we are trying to contend with. But one other thing that's happened now is that because of cost, the US PEPFAR program has encouraged what we call differentiated model of service delivery, where, for instance, patients who are stable can get what they call multi-month scripting, 3 months once their viral loads are suppressed, so they don't have to come every month to the health facility. And particularly, we also have situations where we now find that community support groups can actually do the collecting of these drugs for patients. And in Nigeria now, we have quite a few of the what we call community pharmacists that have been trained so that people can get dispensed at those places. Though that is beginning to have some little challenges because those community pharmacies are nearer to where they live, and some of them don't want to be identified with what they. But it's a problem. But it's been addressed. Talking about research just identifies the problem that we all almost know what they are. But I think it's the operationalization of how to. For instance, in Nigeria, many of our phone numbers are not correct, either deliberately or something. So we find that we now have community support group to say, do you know this person? Can we incentivize you to help us track the person down to where they are in the community? So it's a dynamic thing, but I think there's some progress because it becomes embarrassing. For instance, where you start with 250,000 patients at the end of September last year, and then you come to your first quarter of a new year, you actually have less, despite all the new patients you brought on treatment, than you ended up the last year with. So it's a problem that is being addressed using different modalities.
Okay, so there's a research agenda there for keeping people on. And Maureen, just to follow up on your issue with young women, my experience in Bangladesh was that family planning wasn't working for a long time until women got jobs and actually earned an income. And that changed the number of children they had because they had a reason to go to work and they had a reason to not get pregnant. Are there other ways to encourage young women with opportunities that have been successful? Or do you see a way for that to happen going forward? You're clearly a strong advocate for women. What do you think would be the most influential way forward? Is it the DREAMS program extending that nationwide, or are there other opportunities? How can the government get more involved in that, since that's such a hot spot for all of the countries in Africa where young women are at the highest risk?
Thank you so much for that question. I think definitely, yes, the expansion of the DREAMS program, I think, would be, a key intervention that would be a game changer for the lives of many adolescent girls and young women. Apparently, we have, a strategy which was developed, a national strategy, an AGYW strategy which was developed, which brings together different, ministries within the government, Ministry of Health, Ministry of Education, Ministry of Local Government, just to make sure that, we are not implementing siloed intervention, just, taking us the same way that DREAMS, has been approaching, addressing issues to do with AGYW. But I would say, I think the extent to which that, strategy is being implemented, it's been very slow. So I guess one thing that I would definitely recommend to the government is to make sure that they fully implement that strategy so that it's not just a document that is on paper. Again, we need also to make sure that, adolescent girls and young women have access to youth-friendly health services. This is a challenge in Malawi. We do have, yes, youth-friendly health services, but they're not everywhere. They're not accessible to adolescent girls and young women. So it's very difficult even for them to be able to access these services. And apart from that, education, I think, is going to be very key. That's the only way we can delay, the adolescent girls and young women from getting married early, teen pregnancies, but also having children at an early age. So education is actually going to be key, which the beautiful thing is that DREAMS is already doing that. And I also just want to mention that Global Fund is also implementing a DREAMS-like intervention, which is also focusing on adolescent girls and young women. Of course, the package is quite slightly different, but I think for me, I would want to see more DREAMS-like interventions being, scaled across the country. Yeah.
Okay, so let's get some questions from the audience, if we could, for the panel. I must say that listening to the panel, one of the key links and advances from the PEPFAR program is the building of leadership. And we've had 4 people here on in this session, each of whom has had their career totally changed by investments in their own leadership, in their training, some at Harvard through these programs, through other programs, through programs at Fogarty and NIH and elsewhere, but also in leadership in the country in health. And as I go around myself to different countries, many of the ministers of health and the ministers of science are people who have come out of programs of PEPFAR, programs around HIV, or programs around research. So I think all of you are in some ways products of PEPFAR's leadership activities. So questions from the group? The Global Health Fellows are first to the podium.
Thank you very much for coming from all the way from Africa. And thank you, Doctor from Kenya. Thank you very much for the excellent remarks. As you move forward, one question I wanted to ask for all 4 of you, or one of you, is were you able to convince your local governments to make HIV as a part of the National Health Plan? Specifically, were you able to convince the governments to increase allocation from your domestic resources? That's one. Second, all of you have spoke about we need to transition carefully. We have to sustain this program carefully. I just want you to explain what do you mean by that?
Yeah, thank you for a very nice question. I think for Tanzania, there was no need to convince the government to take HIV in the overall country health plan. HIV is such a big problem in Tanzania that no government officials will even think about, leaving HIV out of the country health plan. So for Tanzania, that wasn't even an issue. The issue of sustainability in Tanzania, it's thought along different fronts. When you look, for example, in the laboratory services, what PEPFAR have done was to make a foundation to create national laboratory services in Tanzania. And that is in terms of national sample referral to ensure that there is a way of transporting sample from a poorest of poor village, very remote, to an area where you can test and then return results. In activity like that, the role of government have been in creating guidelines, in providing healthcare worker, meaning the workforce, to be able to carry out this program, but retain memories and expertise to ensure that this program remain, maybe even after PEPFAR transition out and leave the country. In terms of budget allocation, we have been trying at the level of district to ensure that the district allocate a certain percentage in the health budget to HIV. This has been a progressive, ongoing work. It is still very small. We can't say that it actually accounts for anything. And sometimes in other years, you don't see any budget allocation. So we are trying at least to influence at district level to have HIV budget included. At the national level, the government have been allocating, but it has been less than 5% of all the needed budget for HIV in a year. So we still have a long way to go in that regard in terms of sustainability.
Yeah. For Nigeria, I think the first thing to say is that there had been strategic plans even before PEPFAR came in. The first strategic plan was in 2001, and they've had a series of other strategic plans. As a matter of fact, at the present time, funders are expected to buy into existing strategic plans. But where we do have the issue is that when you now cost these strategic plans and you begin to allocate responsibilities of who will source what, we do have shortfalls. And I think it's not totally a function of government commitment. One peculiarity we have in Nigeria is that in our constitution, health is on what we call the concurrent list. And what that does mean is that the federal government can go get a commitment for the for Nigeria, but that commitment is not binding on the state governor. It's not binding on the local government. So you find that there are pockets there could be good activities at the federal level. The governors might think that's not their priority. If they want to win elections, they want to build roads and all those kind of things. So we've had that challenge. But I think what is happening now is that PEPFAR is now engaging directly with these different levels of government and is beginning to bring some results. When it comes to ownership and sustainability, we've always been told that, there are these three legs, willingness to assume responsibility. Initially, it's like they say, this is your PEPFAR thing. But that's gradually changing now. So there's increasing willingness to assume responsibility. The other one is technical capacity. And I just say that PEPFAR has helped us as a nation that if it was to say, Nigerian technical capacity to run the program, I think there should be no issue with that. But the third one, of course, is that there needs to be financial resources to make this happen. It's increasing, but not at the pace that one will say, it will become truly sustainable soon. So it's half full or half empty.
Okay, Wilson. Questions from the audience? Yeah.
Can I? Okay. Hi, thank you for coming today and offering an international perspective on HIV/AIDS. So I had a question about if you felt that there were religious or cultural practices in each of your countries that affected the implementation of AIDS education programs, and if there are, do you see this changing in the future, this effect or this relationship between practices that I know that can be popular in Africa and AIDS education?
Yes, I think I'll say that, and I think when Mark was presenting or discussing, he really spoke a lot about this. There's no doubt that for many countries that faith-based organizations, for instance, got engaged at the early part of the program, it didn't seem to have the kind of results that we expected them because the drugs were not available to make the difference that we wanted to see made. But I think as the drugs became available, of course, there are some cultural practices that they are still saying, well, this is how we do it here. But generally, I think the barrier is being broken because people are seeing the difference that drugs can make in the lives of people who, and then, of course, the fact that at times these interventions are tailored, that you can have them at faith-based settings and all that. So I want to say that I think the fact that drugs, the greater availability and efficacy of what ARTs have done has kind of broken a lot of the barriers, but those barriers are not totally gone. And I think it's work in progress. You know, we have a lot of the big religious and cultural leaders as advocates that are helping to move things forward.
I just wanted to make a comment, I think, to the area discussion, then I'll come to the cultural issues. She asked about the sustainability of the program, to say, what do we mean by that? So for Malawi, I remember in 2009, Malawi was actually one of the first countries to sign the PEPFAR partnership framework. And the idea behind that was actually to make sure that the government of Malawi becomes this true partner of PEPFAR, but also, kind of preparing the country for that local ownership and self-reliance. Of course, it's unfortunate that to date, since 2009, I can say that almost 90% of the HIV response is still, externally funded. And like I said earlier on, when you look at the fiscal space in Malawi, it's actually very limited, for additional domestic spending. That's not to say that, there aren't other avenues where we can explore. And for me, when I hear programs such as, USAID, journey to self-reliance framework. So for me, what I'm looking forward to is to how can we use such a framework, to help a country, like Malawi, to increase its revenue base, by addressing tax evasion, illicit funds flows. And these are revenues where, avenues where we can be able to generate more resources that can be plowed back into the healthy and HIV response in general. So, otherwise, plugging out, the entire funding, right now for Malawi would actually be quite detrimental. It can actually lead us into regression. So, but I think we need to take, we still need to take those baby steps, to kind of prepare us, into that direction. Now, talking about the cultural issues, indeed, even I think just like Nigeria, there are cultural issues in Malawi as well. But I think what has worked for us is, making sure that we are, targeting the gatekeepers of those cultural values and practices, because most of the times we kind of like sideline them. So when you engage them, you are able to. That's when we are able to make some, some progress and some headways. Yeah, thank you.
Yeah, I just wanted to contribute on that issue of cultural issue. For example, in Tanzania, it's actually quite interesting in a way, because within the government itself, I will just give you an example. The Ministry of Health have a policy for going into, training individuals that, let's say, 14 to 15 on reproduction health, sexual reproduction health, as well as, how they can prevent themselves from, HIV. But the Ministry of Education basically categorically saying, no, you cannot go into schools and provide HIV education. And you can see that tension within the government have a policy for going into, training individuals on reproduction health, sexual reproduction health, as well as, how they can prevent themselves from HIV.
Oh, this. Yes. Nduku, do you want to make a comment? Nduku? You want to speak?
Yes, I do.
Speak away. What is your...
Okay.
Okay.
So can I go ahead?
Yes, please.
Okay, so thanks. I was just listening to the discussions, and I just thought that I would like to just make two quick comments. And the first has been that just thinking about the issues, for instance, of dreams that came up, and just recognizing that, for the thinking about the question about adolescents and young people and being able to reduce HIV infections there also means looking beyond the health sector. And sometimes we haven't been very good at going beyond the health sector, because the issues that I think were brought up by one of the speakers around empowerment, around education opportunity, those are not issues that will be engaged with, reflected with by the health sector, neither will they be funded by the health sector. They sit in other sectors. And in this particular case, you find that, for instance, in Kenya, we have a social cash transfer program for the government. So the question becomes, how do we leverage those other sectors in order to ensure that when, for instance, dreams cannot expand to the whole country, or resources diminish, or there is more that is needed, then that it can plug into already existing programs in order to make it more sustainable and that it can be used into the future. I think the second item I just wanted to make a comment on faith communities is about establishing long-term working relationships with the faith communities. And what we've been able to do is to have a faith sector working group, which means that we are always negotiating different things. Sometimes it will be things as basic as condoms, and sometimes it will be issues that come up like faith healing that we have to think about and see how we engage. And the third comment I wanted to make was on this issue of ownership and leadership, and just say that where we have had significant results in the HIV response has been in countries where this software called ownership by government exists. Where it doesn't exist, there's hardly been as significant or as fast a success, even when there are significant resources. And so it seems in many ways to be, whereas not always very well defined, key to how results are going to be achieved. But also ownership sometimes can result in conflict of priorities and processes between the government and donors and communities. And that, I think, does not always necessarily mean that things are not working. It just means that there has to be a way that we can all talk to each other to be able to find a way of moving forward. And then finally, I think I would just make a mention around thinking, as we think beyond the health sector and as we think about resources into the future, we have to continue to ask ourselves, even if governments take this on, even if there is, because at the end of the day, our governments are the duty bearers. And PEPFAR has provided a lot of support, but fundamentally, the role of resourcing and health security is that of government. How do we ensure that we are building systems that can help perpetuate or that can work within already existing systems, while at the same time building communities to keep demanding? So sorry, I keep hearing on and off, so I hope I'm not too way off the issues that asked all questions. Thank you.
Nduku, we heard you very well and you were very clear. So just to bring this to a closure, I think these 4 presentations have demonstrated first the impact of PEPFAR, of going from a program where Africa was with a huge pandemic to a point now where there are great controls, treatment, we've made great advances. But beyond that, there's the network of human resources for health that's been built up over the past decade and a half. There are the networks for research, such as the AfriHealth group that's brought medical schools and health centers together. There's the interest group, which is like the CROI for Africa, that's brought you all together. So it's really brought together Africans to share experiences from places that are working well and places that are not. It's extended logistics. It's put data into health systems and for policy. It's brought laboratories into public health service, not only for HIV, but for the epidemics of infectious diseases. Grant writing, you've all had to deal with grant writing, which was financial fiscal responsibility, which is not always a high priority in some governments and countries, medical records and training. There's so many aspects of this which we could go on and continue, but I think you've given us a taste of how important PEPFAR programs have been changing in a major way the way healthcare is being delivered in your countries, and reaching out as we go forward to being one of the NCDs as we go into the 21st century. Let me have you all thank the speakers who have made wonderful presentations. And for the organizers who have brought us all together today. I guess it's lunchtime.
I just want to thank our tremendous moderator, Dr. Glass, and this phenomenal panel. Just another round of applause.